Hi, everyone. Welcome to today's webinar. I was just giving it a couple minutes here until we had some more participants joining. Welcome to our Care of the Newborn NCLEX webinar here at Naxlex. I'm really glad that you're all here today. Thank you for showing up for yourselves and being committed to your clinical growth as a nurse. I'm Maria. I'm an RN here at NCLEX, and I'm going to be the host today to teach you about maternal newborn health. Now, in this session, we're going to talk about some newborn assessments, safety, common complications, everything related to the newborn that you need to know for the NCLEX. We do have different topics we go through every week, so that's what we're talking about today. We will be taking a short break halfway through the webinar, which is at about the 1 hour mark, and then we'll come back and continue on with our topics. And of course, I welcome you to give us your input or drop questions anytime in the chat throughout the webinar. Your participation definitely makes the presentation a lot more helpful, a lot more fun, and it makes us feel like a bit more of a sense of community. So again, I'm glad you guys are here. Welcome. If you haven't seen me before, then nice to meet you. And if you have seen me before, then welcome back. Now, before we dive in, feel free to share in the chat when you're taking the NCLEX. How are you feeling about it? And I do see that we have a couple students sharing here. Someone said, please share the link to the PowerPoint. Looks like someone shared a link. And then I'm glad you can hear me. And then I also see a student asking about preparedness. And I just want to share with you that, first of all, congratulations for being consistent with your question bank practice. The score that you're sharing with me is a pretty solid place to be, especially when you're this close to your exam. So a lot of students are right in that range leading up to test day. So remember, the goal is not for everything to be completely perfect, right? It's to show steady improvement. It's to show your strong reasoning and critical thinking skills. The NCLEX is an adaptive test, so it is designed to challenge you. And sometimes feeling stuck at a certain percentage can be very normal. So my advice for you in these last few days leading up to the exam are to focus on priority topics like safety, delegation, prioritization, pharmacology, and conditions that are high yield and known to be found frequently tested on the exam. I also highly recommend that you keep practicing application level questions, not just recall, and that you review your rationales carefully because this is where the real learning happens. Now, most importantly, make sure that you get some rest before the exam. Make sure that you eat a nice meal and that you trust yourself because you've been doing the work and your preparedness is showing. So you've got this. Just stay consistent, do a little bit more practice on the few days leading up to, and you're gonna do just fine. So you don't need perfection; you just need competency. So I hope that helps. Um, oh, I love that. I'm glad to hear that you're watching me on the question bank. That's amazing. The PowerPoint for today's lecture, if you weren't able to get it when you joined, then I will drop it in the chat here. I just dropped a copy in the chat. It is uploading. So when you guys do see that it's finished uploading, it takes a couple minutes. Go ahead and just click on it and it should immediately download to whatever device you are on right now. So let's go ahead and get started here. I'm going to show you a little overview of our topics. So as you know, in the first few hours and days after birth, newborns require very specific care, very detailed nursing assessments and interventions. So these are very high priority topics because it's very important to identify any complications early and also to provide timely care to newborns. That makes a huge difference when it comes to positive outcomes. So, um, we are going to go ahead and talk about the initial care of the newborn, the initial physical examination, assessing the body systems. We're going to talk a little bit about APGAR scoring, cover some safety protocols. We're also going to talk about caring for preterm and small for gestational age newborns, and then managing respiratory distress, and of course, treating hyperbilirubinemia, which is a huge NCLEX topic. And then we are also going to talk about neonatal sepsis and newborn of a diabetic mother. So those are all very important topics. Um, and again, if you have any questions throughout, just drop them in the chat and I will be happy to answer them. Now, before we dive into the details, I want to take a quick moment to kind of talk a little bit about newborn care in the big picture. So, right after birth, a newborn is going to go through a lot of major physiological changes in their body as they're adapting to living outside the womb. And as nurses, we need to provide immediate, thorough assessments to make sure that their transition is smooth. And of course, if the transition isn't smooth, we need to act quickly. Now, the first hours are always going to be critical. We're going to prioritize their airway, their breathing, their circulation, and their ability to thermoregulate. And newborn care isn't just about physical needs either. It's also about promoting bonding between the baby and the family, right? So we want to encourage early skin to skin contact, encourage breastfeeding if that's the birthing person's choice, and also providing emotional support to the parents and education. These are all very essential parts of newborn care. And then, of course, early identification of any complications can really, really improve outcomes for babies. So, your assessments and intervention skills are going to be absolutely vital during this time, especially if you're going into postpartum or maternal newborn health or ER, right? All right. So, now that we've had kind of a minor review of the big picture, let's go ahead and talk about the initial care of the newborn. So, right after delivery, the first thing we're going to do is we're going to start a systematic assessment of the newborn and their basic functions. So, the first priority is always the airway, as our ABCs always tell us. We need to know if their airway is clear of secretions. We are going to suction the mouth first and then the nose if needed. And then, of course, we're going to look at their breathing. We want them to be spontaneously breathing. We want to see good chest movement, and we want to hear clear sounds, right? Not wet sounds. They will be a little bit wet at first, but it should clear. We also want to look at circulation, and by that, we're going to evaluate their heart rate, which can be a bit hard to hear in the clinical setting. Newborn hearts are very fast, and there's a lot of stuff going on. They're crying, so there's a lot of noise, and it's kind of hard to hear them. So it takes a bit of practice, but you really do want to evaluate their heart rate. You want to see if their skin color is good, right? Pink is good, and capillary refill should be good as well. Now, temperature control is another big assessment for newborns because newborns can lose their heat very quickly, and it's very important that we dry them off and keep them warm. So, of course, laying baby skin to skin on mom's chest, as long as both baby and mom are stable, is going to be vital for thermoregulation. And of course, sometimes babies may need to be in the radiant warmer, and that's okay. Now, of course, we're also going to look at baby's neurologic tone and their spontaneous movements. If you have a well flexed baby that's active, this is a very reassuring sign. So, again, we do prioritize our critical thinking skills in these first moments of a baby's life. And it's very, very important to be skilled in our early assessments so we can spot any issues before they, get worse. So once our initial assessments are underway, we will be moving into any life-saving interventions if necessary, right? So, like I said, first, we are going to dry the baby. We're going to stimulate the baby to encourage them to breathe spontaneously. And if they do have any secretions present, we will suction the mouth and the nose very gently, of course. We're going to prioritize their thermoregulation, right? We're either going to do skin to skin with contact with the parent if safe to do so, or we will put them under a radiant warmer. And then within the first hour or so, we are going to be applying the erythromycin eye ointment, if mom and dad are okay with it, to prevent eye infections caused by vaginal flora. But particularly, the eye ointment is meant to prevent eye infections from gonorrhea or chlamydia exposure. Although, if the birthing parent had adequate prenatal care, they should have been tested during their prenatal testing for these conditions. We will also administer vitamin
I have
K.
a question.
Yeah, go ahead.
Um, Even if the child was born by cesarean, are they still going to require the um erythromycin for the eye ointment?
I guess it's standard care for all babies, but if they are born via cesarean, they're much less likely to need it. And at any point, it is also the parent's choice whether the baby gets it or not. So it's not a requirement, it's up to the parent. And not all parents know that. Not all parents know that they're able to say no to it, or that they are able to, consent. But yeah, it's up to the parent. If the parent still wants baby to get it, then yeah, but primarily, it is meant to help baby prevent an infection from gonorrhea or chlamydia exposure. So, and again, when it comes to gonorrhea or chlamydia exposure, um, it could still potentially be something that travels, that ascends upwards. So, the baby is definitely a lot more safe being born via cesarean for that, but it's still something that, the parents might opt to get it still, but babies just have very, very sensitive eyes when they're born, but not all parents opt to have it. A lot of them say they don't want it. A lot of medical staff will delay applying the erythromycin even because it does form kind of like a big goopy glob on their eyes, and it prevents them from seeing their parents right away when they're born and they open their eyes. So they want to either delay it, or some parents don't want it at all because they find it unnecessary. But overall, it is standard care.
Okay, thank you.
You're welcome. So, vitamin K is another one of those that is, whether they consent to it or not. So, if they do consent, which vitamin K is actually a very important intervention, it prevents hemorrhagic disease of the newborn, because their clotting factors are actually immature at birth. So, it is very important for them to receive it, although some parents also don't consent to it, and so that, again, that's going to be up to the parents. But that is another very important intervention. And, better to be safe than sorry. So these actions do have to be completed promptly after birth, usually within the first couple of hours of birth. But sometimes parents want to delay those interventions a little bit, so that they can bond with baby during the golden hour. And that's okay. As long as baby is safe and stable and mom is safe and stable, then they can kind of delay those interventions by an hour or two, to go ahead and, you know, baby can also receive their vitamin K shot while they're laying on mom's chest. So lots of things can be done while baby is already laying on mom, but some of it can be delayed. So another major, major important task during the initial care is actually to assign an APGAR score to the baby at 1 minute and then again at 5 minutes after birth. And it actually assesses 5 areas that are critical to the baby's health: heart rate, respiratory effort, muscle tone, reflex irritability, which is basically response to stimulation, and then color. And then each category is going to be scored from 0 to 2 for a maximum of 10 points. So if baby scores 7 to 10, this means baby is normal and good and adapting well. If baby scores 4 to 6, this means they could have some moderate distress and may need some support. And then 0 to 3 would indicate that baby has severe distress and may even need immediate resuscitation. So APGAR score is very important. It is going to guide our interventions, but it doesn't actually predict long-term outcomes. It's mostly just to assess the immediate needs of the newborn. And then after the initial stabilization, we're going to kind of perform a more thorough head to toe assessment on the newborn, and it's called the initial physical examination. It does help us to detect congenital anomalies, to assess how well the baby's adapting to life outside the uterus, and also to monitor for any early warning signs of complications. So, let's go ahead and dive into it. So, first off, we have newborn vital signs. Now, newborn vital signs are slightly different than the vital signs of older infants or children. As we know, vital sign ranges change by age, right? So, remember to memorize what those normal ranges are and what they mean basically for the NCLEX. What do they mean for the baby as far as anticipating complications? What do they mean as far as interventions go? Now, the heart rate should be between 110 to 160 per minute. And by doing this, we will be using the apical pulse for 1 full minute. So we're not doing 15 seconds and multiplying by 4. We are doing 1 full minute of listening. And like I said, in the clinical setting, this can be a little bit tricky. All right. So basically, we will be looking for any irregular rhythms. For respirations, we really want to have baby be between 30 to 60 breaths per minute. Newborns do breathe very regularly sometimes, so we are going to watch their abdomen because they do use diaphragmatic breathing. We're also going to measure their temperature, and it will likely be measured axillary, and it should be between 97.7 to 99.5 Celsius or Fahrenheit, I mean, and 36.5 to 37.5 Celsius. So babies can lose heat very, very quickly. So that's why we dry them off and try to warm them up right away because they can become hypothermic very fast. And lastly, blood pressure isn't really measured on babies, especially not routinely unless they are premature or if they maybe have some congenital heart disease or if there are any other, abnormal findings that may prompt us to want to check their blood pressure. But if it is measured, we would expect a range of 60 to 80 systolic and 40 to 50 diastolic. So remember to always assess baby systematically to detect any early abnormalities. And of course, we will be assessing the baby's head. So again, systematic head to toe here. So we're going to go through head, chest, and skin. So we are going to check the baby's head. That's going to provide us a lot of information about birth trauma, about their adaptation. We're going to check their fontanelles first and foremost. They should be soft and flat. It's okay if they're very mildly concaved, but they should not be sunken because that could indicate dehydration. And they should not be bulging because that could indicate increased intracranial pressure. Now, the anterior fontanelle closes at about 18 months. That's the one on the top of the head. And the posterior, which is on the back of the head, closes at around 2 months. We're also going to feel the sutures. They should be palpable. They may be overlapping because of that molding process during the birth. And we're also going to look for caput succedaneum, which is a swelling that basically crosses suture lines, but it does resolve within a few days. We also want to check for any cephalohematomas, which is when baby may have a collection of blood between the skull and the periosteum that does not cross sutures. So this could increase the risk of hyperbilirubinemia because of the breakdown of the red blood cells. So if you do find any of that, you need to document the findings and, of course, monitor for any abnormalities that you anticipate over time. Now for baby's chest, you want to focus not just on the lungs, but the heart, right? So we're going to auscultate for heart sounds. S1 and S2 should be present. It is common to hear some murmurs during the first couple of days, but that's because the ductus arteriosus is still closing. So again, they should be transient at this point. We're also going to listen to baby's breath sounds. They should be clear and they should be equal across both lungs. Sometimes they may have mild crackles immediately after birth, but the lungs will be kind of clearing some amniotic fluid, so don't be alarmed. They should not persist or worsen though. We're also going to look at the shape of the chest, right? Newborns will typically have kind of a barrel shaped chest, and that's actually normal. And we're going to watch for signs of distress. Do they have any grunting when they're breathing? Are their noses flaring a lot? Are they having retractions? These are definitely going to be red flags that would require immediate intervention. So you want to notify the physician, get RT in there, and get that baby taken care of. And of course, you're going to correlate any chest findings with the baby's color and activity to spot problems early on. And then, of course, the skin is another very, very important assessment because it does offer a lot of clues about the newborn's health. So the skin should be pink overall, but there is a condition called acrocyanosis, which is very common for the first couple of days in newborns. This is where their extremities will have a bluish tint to them. So if you see that they're pink all over, but their hands and feet are a little bit blue, that's common. That's okay within the first couple of days. Now, you should never be seeing central cyanosis, right? So they should not be blue in the face, in the chest, in the lips, anything like that. But a little bit of bluish tint to the extremities can be normal. Of course, if you see any birthmarks, you want to go ahead and document them, or any other harmless skin findings like Mongolian spots. These kind of look like bruises, so we do want to document those. Sometimes they have just little markings. They may have erythema toxicum, which is a little harmless newborn rash that just kind of looks like a heat rash, like little red pinpoints all over the place. So you definitely want to check for those. And then you also want to check skin turgor to evaluate the hydration status of baby. If baby has poor turgor, that could mean that they are dehydrated or they may have other underlying problems. And make sure that you also check the skin carefully for any lesions or any breaks in the skin or any signs of infection, especially if baby was born with any instrument assistance during birth, like forceps or vacuum. So it is very important to properly document this because later on, normal skin variations could potentially be mistaken for pathology or even for non-accidental trauma. So we definitely need to document things thoroughly to prevent that. Now, after the initial physical exam, we're going to do kind of a deeper dive into the newborn's major body systems to make sure everything's functioning properly. So, the main systems we're going to focus on are cardiovascular, respiratory, hepatic, and renal. So, assessing these systems thoroughly are really going to help us to catch any problems early on, like congenital heart defects, respiratory distress, hypoglycemia, dehydration, all the things that newborns could be at high risk for. And of course, remember early detection. That's what we're all about as nurses, right? This is always going to improve outcomes dramatically. So we want to detect early and intervene early. So starting with the cardiovascular assessment, the heart rate, of course, is going to be the first thing we look at. We talked about how it should be between 110 and 160 at the apical site for 1 minute. We also talked about how murmurs may be normal, right, in the first couple of days because of the closure of the ductus arteriosus. But if you're hearing any murmurs that are loud or that are persistent or abnormal sounding, this could potentially signal congenital heart defects. So you will need to contact the physician for further evaluation. Of course, we also talked about the baby's color, right? Baby should be pink all over. Acrocyanosis is normal, but central cyanosis is never normal and requires immediate action. And then our perfusion check is going to be cap refill. It should be less than 3 seconds, right? So we are going to check both upper and lower extremities for equality. So this one we already know, it's kind of a recap. And then again, we've also talked about the respiratory system, but just as a recap here, the respiratory system does undergo a huge shift at birth, right? So it's very critical to monitor it closely as baby goes from not utilizing the lungs at all to fully utilizing the lungs. So the respiratory rate should be between 30 and 60, like we mentioned earlier. And baby may have periodic breathing, which means they could have little short pauses in their breathing that are about less than 20 seconds each. This is actually normal, so it's nothing to be concerned about as long as it's not causing any additional symptoms, right? Unless baby is looking like they're having difficulty breathing and having maybe some central cyanosis and some pauses, that's different. But if baby is completely, healthy looking and seeming all around, but they're having little periodic breathing pauses, that's normal. Their breath sounds should be clear and equal bilaterally. And again, a little bit of crackles are okay as the fluid is being cleared from the lungs. We also know what signs we need to watch out for when it comes to respiratory distress. So, again, just kind of a mild recap here of what we already talked about. Now for the hepatic system, which we haven't really touched on yet, the liver is still very immature at birth. So we are going to monitor for two major issues, which are glucose and bilirubin. So when it comes to blood glucose, newborns who are preterm, who are small or large for gestational age, or newborns that are born to diabetic mothers are all going to be at risk for hypoglycemia. And the symptoms that you want to look for in a newborn that might indicate that they're hypoglycemic is they would be jittery, they would have poor feeding, they might have a weak cry, and they may be lethargic. So those would definitely be red flag symptoms and should prompt you to check baby's blood sugar right away and get baby fed. Now, bilirubin levels are another thing, right? Newborns naturally have a higher turnover of red blood cells, and they also have an immature liver that may not be clearing bilirubin efficiently. So, this is what could make them at risk for jaundice. Now, if baby does develop jaundice or hyperbilirubinemia, and this gets so severe that it crosses into the brain, it can cause a condition called kernicterus, which is a very serious and permanent neurologic condition. So, we want to make sure that baby is getting fed early and frequently. That's going to help prevent hypoglycemia, and it's also going to support the elimination of bilirubin through stools because the body does eliminate it through stooling. So, the more baby eats and the more frequently, the better. The chances are that baby won't be hypoglycemic and that baby will not have high levels of bilirubin. Now, the renal assessment is also immature at birth, so we do expect some milestones, but we also have to monitor closely. So, the newborn should have their first void within 24 hours. If they have not voided by 24 hours, this does require further evaluation. And they typically say one diaper per day until about day 4 or 5. So by day 4 or 5, we should be expecting like 6 to 8 wet diapers. But up until then, if you're having one diaper on day 1, two diapers on day 2, three diapers on day 3, that's fairly normal. And they may have more too, and that's okay. But this is a good indicator of hydration. So we're going to teach mom to kind of keep at least to track the diapers, or to keep kind of a loose count of how many diapers they've had each day. And also to assess their fontanelle, right? So if baby's not producing urine and baby has a sunken fontanelle, meaning it like dips when you touch the top of their head, if they're having dry mucous membranes like inside their mouth, their nose, and their eyes, and they're not having any tears, or they're having decreased urine output. Any of those symptoms, or one or more of them put together, are signs that this newborn might be dehydrated. And these little babies can dehydrate very quickly, so that is a very big red flag. Now, sometimes in the first few days, you may see a pink stain in the diaper. Some people call it brick dust. This is actually normal. It's not that they're having like hematuria or anything, but it's just some uric acid crystals, and they do resolve as the baby becomes more hydrated. So just encourage frequent feedings. And of course, we need to document urine output in the clinical setting, but we also should educate the parents to track baby's diapers and to be alert to any signs of dehydration. That is a very simple but very powerful tool to monitor newborn well being. And last but not least, we have newborn reflexes. These are a very important part of the neurologic system assessment of a newborn. And it is very important to know these for the NCLEX as well. So here's just the major ones that you should remember. The Moro reflex. This is also known as the startle reflex, and this is when the newborn is startled, their arms are going to kind of fling out and then come back in. So they kind of throw their arms out like this and then put them back in. And then the rooting reflex is when you touch the newborn's cheek, they're going to turn their head toward it, ready to, suckle on a bottle or on a breast, or if it is your finger, they're going to suckle on it. So the rooting reflex is touch their cheek and they turn their head towards it. Now, the sucking reflex is different. That's what happens after the rooting reflex, right? But just to test the sucking reflex, we would touch the roof of the newborn's mouth with the gloved pinky finger, and the baby would start to suck. This is definitely an essential reflex for feeding. We also have the Babinski reflex, which is when you stroke the sole of the foot and the toes are going to fan outward. So you kind of just stroke the sole and the toes are going to fan. This is normal in newborns, but it would definitely be abnormal in adults. And then lastly, we have the tonic neck reflex. This is also kind of known as the fencing position. And this is when their head turns to one side, the arm on that side is going to stretch out, and the opposite arm is going to bend at the elbow. So again, these reflexes are very important indicators that the newborn's nervous system is working well. They have a healthy central nervous system. If any newborns are absent, and if any newborn reflexes are absent, or if they're even asymmetrical, this could suggest that they have some kind of a neurologic impairment, and that would definitely require follow-up by the physician. So, just as a kind of big comprehensive recap here, I just want to make sure that you guys have it all. When it comes to the comprehensive newborn assessment, let's kind of walk through it again, just as a kind of a recap for you or a review. So, the NCLEX really expects you to think um, with prioritizing safety for newborns, with looking at trends, and then with knowing how to differentiate between normal and abnormal findings. So remember, the initial physical assessment in the first hour, we're going to score APGAR first in 5 minutes, right? We're going to evaluate their appearance, their pulse, their grimace, their activity, and their respiration. 7 to 10 is reassuring, but less than 7 may need some interventions. So we're going to start with that before any detailed assessments, especially if the baby is appearing cyanotic, if they're kind of flaccid and not very well toned, or if they're not crying. Then we're going to look at their vital signs, right? We want that heart rate to be between 110 and 160, the respiratory rate between 30 and 60. If they're having a little bit of irregular breathing, that's normal, but if they're having periods greater than 20 seconds of apnea, and if they're having nasal flaring or grunting, that could be a red flag for respiratory distress. We're also going to weigh and measure the baby, right? Head circumference is supposed to be larger than the chest at birth. And if they do have micro or macrocephaly, so if the head is too small or too big for the range, then we need to report that. Hypothermia is very, very dangerous for newborns, more dangerous than fever. So we always assess the auxiliary temperature. Now, the reason why hypothermia is dangerous is because baby will use up more glucose stores to warm up the body if baby's too cold, which could lead to hypoglycemia. So very dangerous. And we do have our measurements here. When it comes to the head to toe focused assessment, the head should be soft. We should have soft, flat fontanelles, which are normal. And if we have any bulging, that could indicate we have increased intracranial pressure. If the fontanelle is sunken, then that could mean dehydration. So again, the head fontanelle, the interior and posterior, they should be soft and they should be flat or very slightly concave. Now, the eyes, they may have a little bit of edema. They may have a little bit of subconjunctival hemorrhage. These can be common for birth trauma. And let's see what else here. Their nose, when it comes to their nose, they are obligate nose breathers. So if their nose, their nares are blocked, This is an immediate airway issue. So we really have to make sure babies' noses are clear. For their mouth, we want to go ahead and assess for a cleft palate and also for that sucking reflex on the roof of the mouth. And if they do have little white cysts on their gums, these are called Epstein pearls and they are normal. For their chest and lungs, we want to look for symmetry in their chest rise, and we also want absence of retractions and grunting. As I mentioned earlier, murmurs in the first day could be from the PDA closing. We're going to monitor, but if the murmurs are persistent, then they may need an echo to further evaluate. Baby may also have breast buds in both sexes, male and female, because of maternal hormones. These are normal, which means their little breasts may be kind of swollen or have little lumps under them. Their abdomen and their umbilical cord. The umbilical stump should have 3 vessels, 2 arteries, and 1 vein. We're going to check this early. If 2 vessels are found only, then we're going to assess for renal anomalies. And the abdomen should be soft, and we should have bowel sounds in all 4 quadrants. For the genitalia, for males, we're going to palpate for descended testes and for urethral position. And for females, we are going to assess that the labia majora is covering the labia minora if the infant is full term. They also may have white vaginal discharge or a pseudomenses that can be normal because of maternal hormones. So they could have a little bit of bleeding or vaginal discharge. And that usually just stays for the first few days as the maternal hormones clear. Now, for the extremities and the hips, of course, we're going to count all the fingers and toes, right? We're going to look for syndactyly or polydactyly. We're going to check the hips. So we're going to perform Barlow and Ortolani maneuvers to make sure there's no hip dysplasia. And for the plantar area, if they do have plantar creases, this could indicate that they are gestationally mature. So no creases means younger. For the neurologic reflexes, right, newborns should be flexed. They should cry when they're stimulated, and all their reflexes should be present. We talked about the Moro reflex, rooting and sucking, the palmar and plantar grasp, and the Babinski, as well as the tonic neck reflex. Now, if the reflexes are absent or asymmetrical, they could potentially have a neurological issue. If they're hypertonic or hypotonic, this is also a red flag. There's also an assessment called the Ballard score, which is done for gestational age. This is used if the gestational age is uncertain. So if mom maybe didn't get prenatal care, wasn't certain, if maybe the ultrasounds weren't, 100%, maybe mom didn't know the last menstrual period for whatever reason. If gestational age is uncertain, we're going to combine some physical traits like skin texture, lanugo, plantar creases with neuromuscular maturity, such as posture and arm recoil. So this will help us identify if baby's too small for gestational age or too large for gestational age. Now, the first period of reactivity of a newborn is the first 30 minutes. This is where they're very alert, and this is the best time to get them feeding. Now, their sleep phase is up to 2 to 4 hours. And then their second period of reactivity, they'll be alert again. So, this is where you're going to observe bonding, attempts of feeding, as well as any behavioral cues. Now, remember the NCLEX may test you on what's abnormal, right? Or what are red flags? What do you need to watch out for? So if you have persistent cyanosis, not acrocyanosis, but persistent cyanosis, especially central, so face, lips, chest, anything like that, that is a red flag. If you have grunting, nasal flaring, or apneic episodes lasting greater than 20 seconds, that's a red flag. If you have hypoglycemia and any other signs of it, like jitteriness, poor suck, poor feeding, a blood sugar of less than 40, that is a red flag. If you have any poor feeding or suck reflexes, or if baby has anything leading up to seizure activity, these are all serious priority findings and they require notifying the provider. So remember to always think in patterns. One abnormal sign may be fine, but if you have multiple, you need to trend those signs and intervene. So that's about all for the assessment. I hope that was thorough. So we do have a few more topics here to talk about. First, we're going to talk about a short topic about newborn safety. This is a high yield topic on the NCLEX as well. And it's mainly about newborn identification as well as preventing newborn abduction and making sure that our parents and our newborns are paired together appropriately and that they stay that way. So, right when baby's born, identification procedures are going to start immediately after birth, right? To ensure that the newborn is always correctly matched with the mother. So, each newborn is going to get an ID band. It's going to be placed typically around the ankle and the wrist. The birthing parent, and then one designated support person that could be mom, auntie, husband, brother, whoever is there, will also receive a matching ID band. So these bands are typically going to include the baby's sex, the baby's date and time of birth, and their MRN or their medical record number. So every single time the newborn is moved, transferred, taken for a procedure, as nurses, we need to verify their ID bands and verify mom and dad's ID bands. Some hospitals may even add footprinting or newborn photographs to increase security, but really this just depends on the facility. So make sure that you always double check the ID band before handing over a newborn because this could prevent any devastating errors. You also need to educate parents on who is allowed to touch or transfer or handle their newborn. So it is part of our scope and our job as well to prevent newborn abduction. It's a very serious priority in every maternity unit. Newborns are usually going to be fitted with that security tag that is going to trigger any alarms if they're moved improperly or if somebody tries to leave the unit with them. And only personnel that are authorized, meaning they are staff and they have visible ID badges, only those people are allowed to transport newborns. So you will be educating the parents like, hey, anybody who touches your baby or is taking your baby anywhere has to have one of these. Their badge has to say this. You have to double check every time. So we're going to teach them to ask to see the badge before letting anyone take the baby anywhere. And of course, their support person may accompany when the baby's taken anywhere as well, as long as it's appropriate to do so. So mother baby units usually are locked. They have locked doors and they have very limited access points that are controlled by security systems and or by staff that's constantly monitoring it. So again, parent education is going to be vital here. We're going to remind parents never hand your baby over without verifying that person's identity first. There have been times where people have gone into locked units. Somehow they got in there. Maybe they stole, a badge, or maybe they put on like scrubs to look like they work there. So that has happened in the past. So again, educate your parents, never hand baby over without verifying that person's identity. And of course, newborns or hospitals take newborn safety very, very seriously. So, as nurses, we are the frontline defenders in these protocols. And of course, each facility is going to have a different protocol when it comes to a child abduction. Now, when it comes to preterm newborns, they are a very high priority population when it comes to nursing care. Preterm is defined as before 37 weeks of gestation, and any baby born before 37 weeks is going to be at much higher risk for problems because their organ systems are still immature. So there are some major areas that we focus on for preterm newborns. We focus on respiratory support because often their lungs will be underdeveloped, and that's pretty much the main system that is going to have trouble. Thermoregulation is another one because they usually can't maintain their temperature. Blood glucose stabilization because they're at high risk for hypoglycemia. And then, of course, infection prevention because they have weaker immune systems. So let's go ahead and look at this section here. And then I do see some questions here. I will take a minute to answer the questions before we go on break. So I will get around to them, I promise. I'm not ignoring you guys. All right, so let's go back here to our preterm babies. So again, preterm newborns are babies that are born before 37 weeks gestation. They will typically have low birth weight. Often it will be less than 2,500 grams. And sometimes you may think preemie and small are linked, but not always. We're also going to cover small for gestational age newborns later in this webinar. But again, preemie does not mean small for gestational age and vice versa. The biggest concern with premature newborns is their immature organ system. So their lungs often will lack surfactant or enough surfactant, which is going to be very important to keep the alveoli open and preventing them from collapsing. They also will have trouble maintaining their body temperature because they'll have very thin skin and very little subcutaneous fat. And their immune system is going to be underdeveloped, which will also make them immunocompromised and susceptible to infections. In addition to that, their neurologic system may be immature, so they may have poor reflexes and tone. And so, of course, understanding these vulnerabilities really helps us to be able to prioritize our care. So when you're assessing a preterm newborn, make sure that you look for any signs of distress. So, for example, if they're having respiratory distress, the signs are going to be the same in a preterm newborn as in a term newborn. They're going to have grunting, nasal flaring, intercostal or sternal retractions. We're also watching out for temperature instability because preemies are so small and they have very little subcutaneous fat. They lose heat very fast, and they are major risk for cold stress, which can worsen their respiratory issues as well as metabolic issues and worsen hypoglycemia. They may also have a weak suck reflex and swallow reflex, which can make feeding very difficult. And you may also see that they are at times lethargic or hypotonic, meaning they have very poor muscle tone compared to a term baby. Again, their skin will be thin, it might be fragile, it might be translucent, and they will lack that subcutaneous fat that term newborns have. Now, because they have such underdeveloped systems, our job is to support those systems, right? So we are going to provide respiratory support, whether they need oxygen therapy, CPAP, or they may even need mechanical ventilation. In some cases, preemies will receive surfactant replacement therapy to help with their lung function to keep those alveoli from collapsing. We're also going to ensure thermal regulation. So we're going to utilize radiant warmers, incubators, and we're going to encourage skin to skin when they are stable, which is also called kangaroo care. We're going to monitor their blood glucose levels very closely because a lot of preemies will need early and frequent feedings or even IV glucose to prevent hypoglycemia. And we're also going to be on top of practicing very strict infection prevention by performing very strict hand hygiene meticulously. We're also going to limit visitors and we're going to monitor for early signs of sepsis. And we are going to talk about neonatal sepsis here in a little bit. We're going to do our best to cluster our care, which means we're going to, do as many interventions as we can at once in order to minimize too much stimulation. So we're going to combine as many assessments and procedures together as we can in order to allow the baby to have longer periods of undisturbed sleep so they can really grow and develop and heal in their sleep. So let me go ahead and chime in here into some of the questions that you guys were asking. Um, so let's go ahead and go through. Let's see here one by one. Starting at the beginning. So is vitamin K given to mom or baby? So that one is given to baby because baby still has immature clotting factors, so it prevents hemorrhaging of the newborn. And then Hep B injection, that's also a choice. Mom doesn't have to choose to get baby the Hep B vaccine at birth, but it is routinely given to all newborns at birth as well. After they get the erythromycin ointment, the vitamin K injection, and then the hepatitis B. Let's see what else here. Is it a first action to clear the airway or to dry the baby first? So typically the first thing they'll do is wrap up baby and dry baby up, so that they're not losing heat through the skin. And then immediately after, they will suction the mouth first and then the nose. That's important to remember. Suction mouth first and then the nose. So um, typically, they won't really suction the baby unless it's obvious that the baby has secretions, and they will do it very gently because that can be a little bit traumatic to their tissue too if they suction too much. So again, drying the baby is always first. So right away they dry off baby so they're not losing heat through the skin. And then if baby does, seem or look or sound like they're having some secretions, then we will clear the mouth and then clear the nose. And when it says, oh, I see you guys saying too, I thought they should be having clear airway routinely because they have been in amniotic fluid. So that is true. They have been in amniotic fluid, but as the baby comes out, they typically clear the secretions naturally, especially as they start breathing. So as they start spontaneously breathing, those secretions kind of just clear on their own, unless there's been, any additional aspiration of meconium or if they've aspirated too much fluid during the birth process, then of course we will suction additionally. So I hope that answers your guys' questions. And we are just about due for our little break here. So I'm going to give you guys a couple minutes, like 3 to 5 minutes at most. And then when we come back, we're going to talk about some more topics. Please feel free to drop more questions in the chat. I love answering questions. So while you guys have me here, ask away. When we come back, we are going to talk about small for gestational age, respiratory distress syndrome, hyperbilirubinemia, and neonatal sepsis. And then, of course, newborn of a diabetic mother. So hopefully we have time to cover all that and then do some questions at the end. Um, but I'll give you guys a couple minutes here, 3 to 5 minutes. Go use the restroom, get a brain break, refill your drinks, and then we'll be right back to talk some more about newborns. So see you guys in a minute. Hi everyone, we are back here from our little break. So let's go ahead and pick right back up where we left off. And then you guys can go ahead and drop any questions for me that you have in the chat, and I'll be more than happy to answer them. So we're kind of shifting our focus now to small for gestational age newborns, which is defined as a baby whose weight falls below the 10th percentile for their gestational age. So this can happen for a number of reasons. There may be some maternal factors like hypertension, malnutrition, placental insufficiency, or even some fetal conditions may cause this. But these babies are basically at risk for certain complications like hypoglycemia, like thermoregulation, or polycythemia, which is when they have an increased concentration of red blood cells. So, of course, we need to go ahead and identify these little babies early to help them thrive despite their small size. And when it comes to a small for gestational newborn, again, physically, they may appear very thin, very small. They may have loose, dry, or peeling skin because they're going to have less subcutaneous fat. And there can be a lot of different causes. Like I said, there could be some maternal factors. So, for example, hypertension, smoking, drug use, poor nutrition could cause this. It could also be caused by placental insufficiency. So, if we have inadequate nutrient delivery from the placenta as well as inadequate oxygen delivery. And then there could also be genetic or fetal factors such as chromosomal abnormalities or even infections. So we are going to classify small for gestational age babies as either symmetrical or asymmetrical. So symmetrical small for gestational age babies are going to be proportionally small in their head, their length, and their weight. Usually this is going to happen from early pregnancy issues, so like an infection or from genetic problems. Now, an asymmetrical small for gestational age baby is going to have a normal head size, but they're going to have a small body. And this usually happens from later pregnancy issues like uteroplacental insufficiency. So it is important to understand how to differentiate symmetrical versus asymmetrical because this helps us to anticipate the outcomes and also to better plan our care. So, to assess small for gestational age newborns, we're going to look first at their appearance. So, they're going to have thin extremities, they may have reduced muscle mass, they may have loose or dry skin, and they will have little subcutaneous fat. In asymmetrical small for gestational age, the head may seem disproportionately large compared to the small body. But in symmetrical small for gestational age, their head will be symmetrical to the body size. They may also have signs of hypoglycemia, so they may be jittery, they may have poor feeding, they may be lethargic, or have a weak cry. And this is because they will have fewer glycogen scores in their little bodies. They're also going to be at risk for jaundice because of polycythemia. So they're going to have way too many red blood cells breaking down after birth. So they may have a yellow coloring to the skin. So, of course, we're going to continue monitoring and assessing carefully to catch any complications like hypoglycemia or hypothermia or any other issues early on. So, the most important interventions for small for gestational age newborns are going to be primarily monitoring blood glucose frequently because hypoglycemia is the most immediate danger for these babies. We have to monitor their blood glucose frequently. We're also going to provide early and frequent feedings in order to stabilize their blood sugar and to support their growth. Now, the feeding, of course, can be by breast or by bottle, or if they're not able to take either, it may be via a tube. We're also going to do our best to maintain their temperature stability. So we're either going to keep them under a radiant warmer or we're going to give them skin to skin to prevent that cold stress. And we're going to monitor for hyperbilirubinemia because we know about that polycythemia, which can increase the risk of jaundice. We're also going to provide as much ongoing developmental support as we can. So we're going to minimize stress, cluster our care, promote bonding, and really try to track their growth parameters closely. So these newborns are definitely more vulnerable, But, with careful care and monitoring, we can definitely ensure that they have healthy outcomes. All right, so we're going to cover respiratory distress syndrome next, also known as RDS. This is a major complication. It's primarily seen in preterm newborns, but it can also happen with term newborns. And it's usually caused by a deficiency in lung surfactant, which can lead to the alveoli collapsing, and that makes it very difficult for gas exchange to occur. So, this is definitely life threatening if it's not recognized and treated quickly. So it is a must-know condition for the NCLEX. And of course, it requires, critical interventions like oxygen support, maybe sometimes surfactant administration. So RDS primarily happens in preterm newborns, especially newborns that are born before 34 weeks. So those are especially at risk. And the underlying cause, of course, is a deficiency of surfactant because the surfactant is a substance. It's very important. It keeps the alveoli, which are the tiny little air sacs in the lungs, open. And without enough surfactant, the alveoli are going to collapse, which makes it very, very difficult for the newborn to breathe and oxygenate and have adequate gas exchange. So, this will lead to decreased lung compliance and impaired gas exchange. And there are some risk factors that can make this newborn a lot more likely to have respiratory distress syndrome. So, like I mentioned, prematurity, especially under 34 weeks. Maternal diabetes is another one because that can also delay surfactant production, and a cesarean birth without labor because labor stress hormones do promote surfactant release. So if baby has like a scheduled cesarean, they could be at higher risk for respiratory distress syndrome. Now, to assess for it, we kind of already talked about it, so it's fairly equal to everything we've mentioned, but it does require you to sharply observe, if baby is tachypnic, so if they're having respirations over 60 um, per minute, we're going to listen to their respiratory effort, right? Are they struggling? Are they grunting to breathe? Is their nose flaring? Are they having retractions, either substernal, intercostal, or suprasternal, because these are going to be red flags as well. And are they cyanotic? I mean, they may be centrally cyanotic, right? So you may see it in their lips and their tongue. These definitely are red flags that are signaling that they have inadequate oxygenation. And when you listen to their breath sounds, they may be decreased, or you may hear crackles as the fluid starts to build up, not just the normal initial crackles that don't persist, but persisting or worsening crackles. So it's very important for you to recognize these signs early so you can provide respiratory support. Now, to manage RDS, we're going to stabilize the airway and we're also going to support gas exchange. So, the first thing we might need is oxygen therapy. So, when it comes to oxygen therapy for newborns, we're going to monitor very carefully with pulse oximetry. Babies cannot receive too much oxygen either. So, their target saturation should be between 90 to 95%, but every facility will have different protocols. A lot of newborns can also require CPAP, which is continuous positive airway pressure machine. And what the CPAP does is it like pushes air into the alveoli to keep them open. So if the newborn does have severe respiratory distress and oxygen therapy and CPAP isn't doing it, they may need mechanical ventilation for some time. We may also administer exogenous surfactant via an endotracheal tube directly into the lungs. This can actually dramatically improve the outcomes in these babies. And of course, we're going to maintain their thermoregulation very aggressively because cold stress can increase oxygen demand, which can worsen their respiratory distress even further. So, warm babies are happy babies. Not too warm, though. And of course, in the midst of all this, we're going to make sure to practice very meticulous and strict infection prevention because any additional infection or pathogen could further compromise their lung function and just increase the risk exponentially of complications. So remember, being that nurse that has that sharp observation skill, catches, any of these signs early on and intervenes rapidly and early can make all the difference between life and death in these newborns. Now, moving into hyperbilirubinemia, this is another high yield topic. We see it talked about a lot in question banks. This condition refers to excess bilirubin in the bloodstream, which can cause visible jaundice, which is that yellow discoloration of the eyes and the skin. Sometimes mild jaundice can be common in newborns because they already have a little bit of elevated bilirubin levels. But if the levels are really high and they're left untreated, again, they can lead to kernicterus, like I mentioned earlier. So we do play a very vital role in recognizing that. So again, hyperbilirubinemia happens when you have that excess of bilirubin, which is a yellow pigment that's released when red blood cells break down. And newborns naturally have a higher red blood cell turnover and they have a mature liver. So they have kind of a combination that makes it perfect for this to happen. They could have something called mild jaundice or physiologic jaundice, which can be normal. There could be other causes too, like breastfeeding jaundice, which can happen if the baby isn't transferring enough milk initially. If they're having poor latch, poor feeding, a little bit of dehydration, this can happen, but it does resolve. Or we could have it happen from hemolytic disease, such as when baby has Rh incompatibility or ABO incompatibility, which can cause red blood cells to break down rapidly. But again, if those levels of bilirubin climb too high, they will cross the blood brain barrier and they will cause irreversible brain damage. So that's why we monitor them so closely. So to assess, it does involve visual and lab evaluation. So first, it's going to appear in the face and the sclera of the eyes, right? So you're going to see a bit of yellowing to the face and the eyes, and then it's going to move downwards to the chest, the abdomen, and the legs as the bilirubin levels are rising. So if you're seeing this pattern, you need to intervene immediately. Now, serum bilirubin levels need to be measured also in order to determine how severe it is and what treatment the baby needs. So the timing is going to be very crucial for you to understand when it comes to the NCLEX. So physiologic jaundice is going to appear after 24 hours of life, okay? So this is usually a benign condition. So again, physiologic jaundice, which is also like mild jaundice, this will happen after 24 hours of life. There may be a little bit of mild yellowing, but this is benign and it will resolve on its own. Now, pathologic jaundice is the one that we want to watch out for. This is the one that appears before 24 hours of life or within the first 24 hours of life. This is always, always concerning. And it does suggest that the baby may have that underlying disease. So, again, before or within the first 24 hours, pathologic, red flag. But if it's after 24 hours, physiologic, it's benign. So make sure that when it comes to these babies, you're monitoring their feeding patterns and any weight loss because poor intake can worsen jaundice by reducing the elimination. So remember, I told you guys that bilirubin is eliminated through stooling and bowel movement. So the more baby feeds, the better. So if baby doesn't have a good latch, baby doesn't have, good feeding, they're losing weight, they're not producing a diaper, this could make the jaundice worse because now the bilirubin can't be eliminated through the stool. So the interventions for hyperbilirubinemia are going to help lower the levels of bilirubin in a safe manner. So first and foremost, we're going to encourage frequent feedings, right? So either breast or formula, again, because it's eliminated through stool, more feeds equal more poops, which equals lower bilirubin. Now, of course, if their levels are really high, we're also going to add phototherapy, which is a special light treatment that helps to break down the bilirubin into a water soluble form that the baby can excrete. Now, if you have a very, very, very severe case, the baby may need an exchange transfusion. which is when they replace the baby's blood to rapidly lower bilirubin. So that is very rare and very severe, but it can happen. Now, of course, we're going to continuously monitor the bilirubin levels with blood tests. So we're always going to watch out for signs of bilirubin encephalopathy. So if baby is showing signs of lethargy, hypotonia, so if they have poor muscle tone, poor feeding, high pitched cry, these can be signs that the bilirubin is increasing, it's becoming worse, and that they could be going into kernicterus, which is when they get that irreversible brain damage. So there are some care points that you need to know when a newborn is under phototherapy. So you have to know these nursing actions in order to keep them safe, but also in order to maximize the effectiveness of the treatment. So first, you're going to expose as much skin as possible. So the newborn should be completely undressed with the exception of their diaper in order to maximize light exposure. You're also going to protect their eyes with eye shields to prevent damage to the retina from the bright lights. And you are going to monitor their hydration very, very closely because phototherapy can increase fluid loss, which can raise the risk of dehydration. So, baby needs to be fed frequently, and baby will be removed to be fed and then put back under phototherapy. We're also going to reposition baby every 2 hours because we need to ensure that they're having even light exposure all throughout the body. And of course, we're going to continue to track their serum bilirubin levels because we need to determine how effective the therapy is and when we can stop it. But we should also let parents know and educate them that they may have some mild side effects. So they could get a mild transient rash or they may have some loose stools. Generally, these things are going to be harmless, and they should also know not to apply anything to the baby's skin when they are going into phototherapy. Now, before we finish that section, I do have some mnemonics to kind of help you remember some points from today. So, for newborn assessment priorities, I have ABCs plus TNT, which is focus on airway, breathing, circulation, plus temperature, neurologic tone. And then for the respiratory distress syndrome signs, I just put GNR for grunting, nasal flaring, and retractions. This is actually the classic triad of respiratory distress, so remember those. And then for jaundice timing, we have that super simple rule of 24 okay, but before 24, it's an emergency or a red flag. And then to describe a small for gestational age newborn, we put tiny, thin, and tired. So they're going to be small, they're going to have less fat, and they're usually going to appear very sleepy, weak, or lethargic. And then for phototherapy nursing care, the mnemonic is BEEP, which is bare skin, eye protection, every 2 hours reposition, and P for push fluids to prevent dehydration. So just some little shortcuts to lock these things into your memory. Now, our last topic for the day, actually, our before our last topic, because we have neonatal sepsis and then newborn of a diabetic mother. So, neonatal sepsis is a very important topic because it is a life threatening systemic infection in newborns. It can be caused by bacteria, by viruses, or by fungi that invade the bloodstream. Now, there's two classifications for neonatal sepsis. We have early onset sepsis and late onset sepsis. So, early onset is going to happen within the first 72 hours of life, and usually it's going to be acquired vertically from the mom, often during the birth. So this could be then late onset sepsis is going to be after 72 hours. So this is typically going to be from hospital or from community exposure. So the most common pathogens from vertical exposure could be group B strep, E. coli, listeria. Viral causes could be herpes simplex virus. So if mom has like active herpes lesions, a C-section is required so that baby isn't exposed to that because that can and will cause neonatal sepsis. Now, some babies are at much higher risk for developing neonatal sepsis. So if they're premature, They do have a weaker immune system, so that's definitely something that puts them at higher risk. If they have a prolonged rupture of membrane, so if mom has had the water broken for greater than 18 hours, um, then baby is going to be at a higher risk for neonatal sepsis. If mom had chorioamnionitis, so a uterine infection, right? So when mom has prolonged rupture of membranes, mom is at risk for chorioamnionitis. And if mom develops that, then baby's also at risk for neonatal sepsis. Now, if mom has GBS colonization, so if mom is GBS positive and doesn't receive antibiotics during the delivery, that can be very dangerous for baby. And if baby has any invasive procedures like central lines, intubation, these can also put baby at risk for neonatal sepsis, and it can cause them to deteriorate very quickly. So, again, early recognition and intervention here. So assessment is going to be everything because newborns are going to have some non-specific signs of sepsis, or they'll be very subtle. So some of the classic signs are going to start with temperature instability. So baby either will be hypothermic or develop a fever, but most likely they will become hypothermic. If they have any behavioral changes, like they're lethargic, they're extra irritable, they have a poor suck reflex, or they're refusing to feed, that is a red flag. If they're having respiratory symptoms, like our classic triad, grunting, nasal flaring, if they're having apnea or tachypnea, that is a red flag. If their skin is having any signs of shock, so if they have mottled skin or pale skin, or if they're having poor cap refill, or if they have low blood pressure. So if baby does have a lot of these signs and we're suspecting neonatal sepsis, it could, progress to neonatal sepsis that is more severe, and it could lead to seizures. It could lead to a very neurological red flag, which is a high pitched cry. It could lead to a bulging fontanelle, which is when they're having an increased intracranial pressure, or that could even be a sign of meningitis. So, again, these are going to be like top red flags that you really, really want to act quickly on. The other ones that I gave you were early red flags. These are late red flags, right? So, high pitched cry, bulging fontanelle. Their labs are going to likely have an increased CRP. So their C reactive protein is going to be high. Their white blood cells will be abnormal, right? They'll either be elevated or they'll be low and neutropenic. And they may have positive cultures. So they may have positive urine cultures, blood cultures, or CSF cultures. So when it comes to newborns having any of these signs, they are going to get the full workup, including an LP. So they will be checking everything. So if you see any wording on the NCLEX, like lethargic newborn or infant with a temperature of 96.8 and poor feeding, this is where right away that red flag should go off in your head for sepsis, and you need to act quickly. Now, of course, fast and immediate interventions are going to save lives. So, first, you're going to initiate your neonatal sepsis protocol that is according to your facility, right? But just for standard care when it comes to the NCLEX, the first thing you want to do is obtain labs, right? So, you want to draw blood cultures, urine cultures, CSF cultures. Um, you want to get a CBC, a CRP. You want to check that baby's glucose and their electrolyte panels. And then next, you're going to administer IV fluids and broad spectrum antibiotics without delay, right? So generally, you should be getting those labs and immediately start the fluids and antibiotics. They may be given agents like ampicillin or gentamicin, and we will adjust them once the cultures do return with any specific pathogens, but we will start them off on broad spectrum. And during that treatment, the course of treatment, our priorities are going to include, of course, thermal regulation, right? So we're going to make sure that they have dry linens, that they're in a radiant warmer. We're going to continuously monitor their blood sugar. So we know that sepsis can cause hypoglycemia, so we're going to frequently get that blood sugar, and we're going to monitor their cardiac and respiratory status because they can crash so fast. We're going to watch for apnea and bradycardia, and we're going to handle them minimally, as we talked about earlier, clustering our care, right? We need to reduce their energy expenditure, and their stress. So we're going to cluster our care and let them rest as much as possible. And we're going to stay in touch and communicate with that provider early on, and also educate the parents very gently about the seriousness of the condition, right? Now, if a culture hasn't been drawn, but we suspect sepsis, we always draw the culture before starting antibiotics, but we also will not delay treatment to wait for results. So just remember that. So a quick little review here of neonatal sepsis. If a newborn is hypothermic, lethargic, and not feeding, what's your priority? That would be to notify the provider and initiate a sepsis protocol. What is the most common cause of early onset neonatal sepsis? That would be group B strep. So again, that's why all moms get tested for GBS. They get that um, swab. They get swabbed vaginally and rectally in the third trimester. And then if they are GBS positive, they will be receiving antibiotics. If not, then we're good to go. Which two antibiotics are commonly started empirically for neonatal sepsis? We have ampicillin and gentamicin. Why is hypothermia a concern in neonatal sepsis? This is because newborns may become cold, not febrile, because of their immature immune response. And what lab should you expect to draw during neonatal sepsis workup? We're going to get a CBC, a CRP. We're going to get urine, blood, and CSF cultures. Now, last topic, but not least here, we have newborn of a diabetic mother, also known as infant of a diabetic mother, or IDM. So infants that are born to moms that have gestational diabetes are called IDMs, and they usually have a unique risk profile here because in utero, the mom's high blood glucose is going to cross the placenta, but the insulin won't. So the fetus is going to compensate by producing its own high levels of insulin, and this is going to lead to excess growth, which is also known as macrosomia. And it's also going to lead to organ immaturity, especially in the lungs. So once the umbilical cord is cut, the maternal supply of glucose ends, right then and there. But then the infant will still have those high levels of insulin circulating in their body, which is going to lead to neonatal hypoglycemia, which of course is a major concern on the NCLEX and clinically. And there are other potential complications too. So, for example, birth injury, if you have a macrosomic baby who is very large, they may suffer from, let's say, shoulder dystocia. You may have respiratory distress syndrome because insulin interferes with surfactants. And you may also have polycythemia, which is those increased red blood cells because of chronic hypoxia, and then hypocalcemia and hyperbilirubinemia as well. So, of course, we need to be able to recognize these risks and provide anticipatory care for these babies. Now, the assessment starts at birth. So, especially if we know the mom is diabetic or has gestational diabetes, the baby may appear very large, very well fed, but they're still at risk for complications. Like, for example, the number one is hypoglycemia. So, again, we're going to look for jitteriness, poor feeding, apnea, cyanosis, or even seizures. And some of them will also show signs of respiratory distress, even if they're full term, because of that delayed surfactant production from the insulin. Now, macrosomic babies that are very large may have birth trauma. They may be hypotonic, or they may have a hard time regulating their temperature. We're also going to assess their skin color. They may be have a ruddy appearance to them, which puts them at risk for jaundice. This is that polycythemia we talked about. They may also have twitching, tremors, or irritability, which would be a sign of hypocalcemia. And of course, if they have jaundice within the first 24 to 48 hours, that would signal that they also have hyperbilirubinemia. So try to be proactive about checking labs. Check the blood glucose within 30 minutes of birth. If you know mom is diabetic, we have a large baby, we need to go ahead and check within the first 30 minutes of birth. And then, of course, we're going to check regularly depending on what their blood glucose was and also how often they're being fed. Now, the nursing care is going to focus on early detection and prevention of hypoglycemia and the other complications as well. So again, we have checking that blood sugar within 30 minutes of birth and then initiating very early feeding, right? So preferably breast milk, but also formula to stabilize the glucose, but preferably this should be done within the first hour of birth. Now, if the blood sugar is below the threshold, we're going to repeat the check before the next feed, and then we're going to watch to see if baby is having any signs of decompensation. If baby is symptomatic or they remain persistently low with their blood glucose, we will initiate IV dextrose therapy, usually D10W via IV bolus or a continuous infusion. We're also going to continue monitoring their temperature. So we're going to keep them warm to reduce the energy demand. We're going to make sure that they don't have any respiratory distress. If they do, they may require oxygen therapy or even a NICU transfer. We're also going to monitor their hematocrit and their bilirubin. And we're going to watch them for hypocalcemia. So again, any twitching, any tremors, anything like that. And we will educate the patient's parents as well about the need for constant monitoring so they can understand why we're doing that. And also we will reassure them that as long as the baby has early interventions, they will do well. Now a quick Q&A here at the end just to review what's the most common metabolic complication in an IDM, and that would be hypoglycemia. What's the earliest nursing action? If an IDM is jittery and lethargic, that would be right away to check the blood glucose. If a macroscomic baby is born to a mom with GDM, what complications should the nurse anticipate? We're going to anticipate respiratory distress syndrome, right? But we're also going to anticipate hypoglycemia. But again, this is what is the best feeding plan for a stable infant of a diabetic mother? That would be early feeding, right? Whether it's breast or formula, we just want them to feed early and feed frequently, and we're going to monitor their glucose. And then, of course, the lab values that are going to be priority for us to monitor are glucose, calcium, bilirubin, and hematocrit. So that just about ties it up for the topics that we had to talk about today. So I am going to go ahead and jump into some questions for us here, some application questions. So I'm going to go ahead and share my screen with you, and we'll do as many as we can before the time runs out. But I do see some questions that you guys are asking in the chat here. Let me see. So I have, why is the infant of a diabetic mother at risk of hypocalcemia? And also, did you say hyperinsulinemia at birth delays surfactant production? So why are they at risk for hypocalcemia? So we don't really understand the full mechanism of that, but the main reason that we know is because their parathyroid hormone is suppressed. So maternal diabetes causes an altered metabolism of calcium and magnesium, which means the baby's parathyroid gland becomes less responsive. So then after the baby's born, when the baby's calcium supply is cut off from the mom, right, umbilical cord's cut off, they're no longer receiving nutrients from the placenta, then their body starts to struggle to maintain normal calcium levels. So typically in infants of a diabetic mother, hypocalcemia will appear within 24 to 72 hours after birth. So it won't be immediate, but it will have similar symptoms to the other complications that we know about newborns. So if they're jittery, they're irritable, they're having a high-pitched cry, they're maybe having tremors, they're apneic, they are having cyanosis, or again, seizures in very severe cases. So if you do see an infant of a diabetic mother that's jittery, you're always going to consider hypoglycemia first, but a secondary cause could be hypocalcemia. Now, when it comes to hyperinsulinemia and surfactant production, these are definitely connected. So in infants of a diabetic mother, the baby has chronic hyperinsulinemia, which means they were exposed to a lot of maternal glucose in utero, so their bodies, were producing a lot of insulin. Now, the problem is that insulin actually antagonizes cortisol, and cortisol is needed for production of surfactant in the lungs. So the result is that the synthesis of surfactant ends up being delayed, which increases their risk for respiratory distress syndrome, even if they're born at term. So even if they're full term, but they're being born of a diabetic mother, they have that hyperinsulinemia, they may have that delayed synthesis of surfactant, which increases their risk for respiratory distress syndrome. So, but the good thing is that most babies do make enough surfactant, usually by week 34 to 36, which is why we consider babies that are born before 34 weeks more at risk for respiratory distress. But infants of a diabetic mother are at higher risk for respiratory distress syndrome, even at term, because of that hyperinsulinemia delaying the synthesis of surfactant. So I hope that makes sense, and that I answered that for you. So let's go ahead and jump into some questions here. Let me see if I shared correctly with you guys. Okay, so we have a nurse caring for a neonate in the postnatal unit, and the neonate was delivered via spontaneous vaginal delivery at 40 weeks gestation. The labor was prolonged, with the second stage lasting over 2 hours. The attending provider noted shoulder dystocia during delivery. The neonate cried immediately after birth, but has since shown minimal spontaneous movement in the right upper limb. No bruising is noted. Feeding attempts have been difficult with a weak suck. The neonate appears irritable during handling and is particularly fussy when the right arm is moved. Parents report concern over persistent asymmetry when holding the baby. So the medical history was that the baby was full term at 40 plus 1 weeks. The maternal age was 35. GDM was diet controlled, no antenatal infections, no intrauterine growth restriction. Birth weight was 8.4 pounds. APGAR scores were 8 at 1 minute, 9 at 5, and no congenital anomalies identified. Vital signs are temperature 98.1, heart rate 142, blood pressure 68 over 42, oxygen sats 96 on Romer, respiratory rate 52 breaths per minute. The neonate is alert, responsive to auditory and tactical stimuli. The right upper extremity is held in adduction and internal rotation with absent Moro reflex on the right side. There is more decreased spontaneous movement in the right arm compared to the left. Passive range of motion at the shoulder and elbow elicits a mild grimace. There's no swelling, erythema, or crepitus over the clavicle or humerus. The grasp reflex is present bilaterally. The neck movements are symmetric, and the spine is without abnormalities. Tone is appropriate in lower extremities. Pupils are equal and reactive to light. We have a white blood cell count of 9,300. We have a C-reactive protein of 0.6 and a serum glucose of 42. So everything is within range. Although the blood glucose is a little on the low side, but it's still within range. Blood cultures are pending. Head ultrasound showed no intracranial hemorrhage, and radiograph of clavicle shows it's intact without fracture. So now we're going to choose what condition the client is most likely experiencing, what actions we need to take, and we're going to choose two, and then what parameters we need to monitor. So does anybody want to shout it out, or do you want to share in the chat? So let me know. We have our options here for macrosomia, congenital muscular torticollis, neonatal brachial plexus palsy, or neonatal hypoglycemia.
C.
Yes, C. Okay, perfect. And then what actions do we take? We need to choose two options here. So we have assisting with blood glucose, initiating phototherapy,
C
positioning.
and E.
Oh, love it. C and E. So position the neonate to avoid pressure on the affected limb and immobilize the affected upper limb with a rigid splint. Now, what parameters are we going to monitor? We have blood glucose, neurostatus of the right upper extremity, serum lactate, direct and indirect bilirubin, and abdominal girth to monitor for hepatomegaly.
A and B.
Blood glucose and neurovascular status. All right, let's go ahead and take a look. So you're correct. Neonatal brachial plexus palsy, excellent job. And then C and E and A and B. So you guys did amazing. So let's talk about the rationale. So neonatal brachial plexus palsy can happen with shoulder dystocia, right? Which can happen with macrosomic babies. As we know, this mom was diabetic. So the right arm is being held in adduction and internal rotation. They have an absent Moro reflex, but they still have a preserved grasp reflex. So this means that we have Erb's palsy, which is the involvement of C5 and C6. There's no fracture, right? So this fits that clinical picture. There's normal tone, there's no bruising, there's intact reflexes everywhere. So that means the baby has a healthy nervous system, right? So it's not really a neurologic cause. It's more so a skeletal cause. So this injury can happen with large for gestational age infants that have a prolonged second stage and traction forces. So our actions here are going to be positioning the neonate to avoid pressure, right? This is going to help to prevent any further complications or additional injury, and it's also going to support their natural recovery. And then immobilizing them is also going to help to rest that limb, and it's going to help to prevent contractures, and it's going to help to promote recovery. So let's see here. Now, our parameters that we're going to monitor. Capillary glucose, right? Why? Because we know that not only was the mom diabetic, but also because of that neonatal brachial plexus palsy, that could mean that their feeding and suck reflex could potentially be impaired. So they could be at risk for hypoglycemia. And of course, if they're increasingly irritable and they're having decreased intake, their energy demand is going to be higher, which means they're going to be utilizing more of those glycogen stores. Now, their neurovascular status needs to be assessed because we want to make sure that they have proper perfusion, that they have proper motor function, and that we're monitoring for any potential complications like edema or even compartment syndrome. So if they're having any hypoperfusion or delayed cap refill, that would be a red flag for vascular compromise. So great job on that one, you guys. So let me go ahead and get another question going here. So we have a nurse in the obstetric unit assisting with the care of a client. And we have a 38-year-old client that's gravid 3, pair 2, and is at 42 weeks of gestation. So we're post-term here. Client is being induced after a non-reactive, non-stress test, positive contraction stress test, and a biophysical profile score of 6. Previous pregnancy was complicated by GDM and gonorrhea. Current pregnancy is uncomplicated. Client has refused induction of labor before today, stating, I want nature to have a chance to work. But upon examination, the client's cervix is dilated 1 centimeter and 40% effaced at -1 station, soft and anterior. For induction, we're using oxytocin. So, which of the following findings places the fetus at risk for complications during labor and the neonatal period? Select all that apply. Oh, let's see here. So we have maternal age, non-stress test results, cervical exam, contraction stress test results, gestational age, previous pregnancy history, and biophysical profile results. What do you guys think? Drop it in the chat or shout it out loud.
Gestational age.
Yes, absolutely.
2, non-stress test.
Yes.
Biophysical profile results. And 4, contraction stress test.
Beautiful. Let's take a look. So you guys are correct. Non-stress test results, contraction stress test, gestational age, and the BPP, right? So great job, you guys. Excellent work. So a post-term pregnancy definitely has a risk to both mom and baby, right? Especially because of placental insufficiency. That's actually the major concern because that means it's almost like the placenta is like expiring. So it's no longer, transferring oxygen and nutrients the same way that it has throughout the pregnancy. Now, we could potentially also have a lot of other complications that can come along with that, right? So that contraction stress test is evaluating the fetal response to uterine contractions, and the biophysical profile is actually assessing the fetal well-being by using ultrasound and fetal heart rate monitoring. So let's go ahead and look at why each one was an indication of a high risk, right? So of course, the non-stress test Being non-reactive means we potentially have fetal compromise. That means the fetus's central nervous system isn't reacting appropriately to stimuli. Now, the contraction stress test is indicating that the fetus is potentially in distress in this case. The gestational age of 42 weeks could potentially point to placental insufficiency and macrosomia. So the baby could be big, which could lead to labor dystocia. And then lastly, we have that biophysical profile that is that score of 6 is definitely indicating that the fetus is compromised. So definitely, you guys did an excellent job here. Cervical exam findings, pretty standard, not normal, right? They don't really put the baby at risk. The maternal age of 38 is advanced, but by itself is not really a risk for complications. And then the previous pregnancy history, it's important for history, but it doesn't put the fetus at this point at risk for complications during labor. So great job, you guys. Let's see here. Drag words from the choices below to fill in each blank in the following sentence. So let me try to go down here. So the fetus is at risk for developing blank and blank. So what do you guys think? We have a few options here. Late fetal heart rate
Late,
deceleration. Sorry, go ahead.
late fetal heart rate deceleration.
Okay.
Yeah. In response
Hypoxemia during
to
labor.
hypoxemia and the alkalos,
All right, let's take a look. So
Hypoxemia
you
during
guys are absolutely correct. You nailed it. You guys have been nailing it every single question. I love it. So absolutely late fetal heart rate decelerations and hypoxemia, right? So why is the baby at risk for these? Now, for the late decels, this happens because of uteroplacental insufficiency, right? So remember our veal chop mnemonic when it comes to decelerations and knowing why are they happening, right? So late decels happen because of uteroplacental insufficiency. This means the baby can't get enough oxygen, right? So um, basically this could potential that the baby is compromised and we need to intervene in order to improve oxygenation. Now, the hypoxemia, this is because of that compromised oxygen delivery, right? So we just talked about uteroplacental insufficiency, which means the baby isn't getting enough oxygen, right? So if the labor is prolonged and baby is, having late decels and not having enough perfusion delivered through the placenta, then the baby is going to be highly stressed during those contractions, because when the body is contracting, the baby's head is already being compressed and they're losing a little bit of perfusion during that time. But if they're already stressed plus the process of labor, that can be extremely dangerous for babies. So again, this would mean that mom needs to be very closely monitored. And, of course, we need timely interventions to make sure nothing's going on. Now, why didn't we choose alkalosis, right? So in this scenario, this baby would be more likely to have acidosis because of the reduced oxygen rather than alkalosis. Alkalosis would be more so from metabolic issues. Now, the brachial plexus injury, this could be more so if the baby has excessive traction during delivery or if the baby is macrosomic, right? So at this point, we're really more concerned about perfusion. And then retinopathy of prematurely, this was more so with preterm infants as well as high level of oxygen. Remember earlier I talked about babies can't receive too much oxygen either. So that could cause retinopathy. Now, this isn't really relevant in this scenario, so you guys nailed it. All right, let's read the next one. So we have a primary cesarean birth performed at 1600 due to non-reassuring fetal status. The client is in stable condition. The baby is viable, 6 pounds, 12 ounces. It's a male. And the baby was transferred to the NICU for observation. At 1600, the newborn was on the radiant warmer, dried, stimulated, and bulb suction performed. Then at 1601, the newborn is cyanotic with gasping respirations. Heart rate is 80 with minimal muscle tone and minimal response to stimuli. APGAR score is 4. So let's go ahead and answer the question. If I can pull it up here. So the nurse should first assist in addressing the newborn's blank, followed by the
respiration.
newborn blank. So first, yep, we have here respiratory status, weight, and skin color, and muscle
Respiratory
tone,
and
heart
heart
rate.
rate.
Absolutely. You are correct. You nailed it. Respiratory rate and heart rate. Thank you so much for your wonderful answers. So, of course, the respiratory status, right? That's our ABC order here. We got airway, breathing, and circulation. So, respiratory status, baby's cyanotic and gasping. This can be fatal to babies. So, baby should be breathing between 40 to 60. So we have to administer oxygen at this time and have that neonatal resuscitation team nearby working on this baby and ensuring that the baby is adequately being ventilated. Now, the heart rate is next, right? Babies that are 80, that is really low. They're supposed to be like
Yeah.
110, 120 to
110,
160.
160.
Yeah, absolutely. So bradycardia means their cardiac output is compromised, their systemic perfusion is compromised. So they may need compressions or they may need epi. So again, depending on the facility, depending on the protocol, but they definitely need help right away. So great job. Now for these other categories, weight, skin color, muscle tone, stimuli, again, these are all, the birth weight wasn't necessarily a concern, but the cyanotic skin color was a concern. However, that's just a symptom of the respiratory distress, right? The poor muscle tone, also a symptom, right? That's just showing us that their system is compromised, but it's secondary to their respiratory and cardiac issues and will probably improve after, those interventions are applied. And then again, that stimuli response is the same thing that will improve once cardiac and respiratory status are handled. Now for our next question, we have for each of the following nursing interventions, click to specify if it's anticipated or not anticipated in the care of this newborn. Let me go ahead and stop sharing because it looks like I have some answers in here, and I'm going to go ahead and erase them real quick for you guys so we can go through it together. All right, I'm going to go ahead and share my screen again. Let me see here. Beautiful. So let's go ahead and work through these. First, we have initiate chest compression. So what do you guys think? Is this anticipated or not
No,
anticipated?
it's not.
None.
All right. What about monitor oxygen saturation?
Yes.
Yes.
Anticipated.
Mm-hmm.
Yeah.
Yes.
What about assist with administering 0.9% sodium chloride?
Anticipated.
Yes.
No,
Anticipated, yeah.
no,
All
I
right.
think it's not. I don't know.
no.
Are
It's
we saying
not.
yes or no?
No.
All right, let's go with not, and then obtain cord blood specimen for lab testing.
Anticipated.
All right, let's go with anticipated. So let's look at our answers now. We have not anticipated for chest compressions. We have oxygen saturation anticipated. We have IV bolus not
Yeah.
anticipated. And then we have cord blood anticipated. So excellent job. You guys definitely nailed it again. So why are we monitoring oxygen saturation? Well, because the newborn is in respiratory distress, right? They're cyanotic, they're having gasping respirations. We need to assess how effective our treatment is and if they're stabilizing. So they should be above 90% after 10 minutes or by 10 minutes after birth. Now, why are we getting cord blood specimen? Because we need to assess them. Do they have any metabolic disturbances? Are they acidotic? Because they've been hypoxemic for so long. So again, their umbilical artery pH should be between 7.2 to 7.3. Now, why aren't we initiating chest compressions? Well, their heart rate is 80. It's definitely above 60. At below 60, we would likely be initiating chest compressions. So if the heart rate doesn't improve once we start adequately ventilating them, then we may initiate compressions to enhance that perfusion. So we want to get their heart rate to 120 to 160. And then why aren't we giving a bolus? This isn't really a first line intervention for respiratory and cardiac distress, but we would give it if the newborn was hypovolemic or hemorrhagic, but there's no indication that they are in this case. All right, so the heart rate is 120 per minute, respiratory rate is 48 with a strong cry, some flexion of the extremities noted, and the newborn is now grimacing with stimulation. Their central cyanosis has been resolved, but they're still acrocyanotic, which is normal. Now the nurse is documenting the newborn's 5-minute APGAR score. What should the nurse document? So according to these new findings, what do you guys think?
8.
7.
All right, let's take a look. So it is
7.
7. Great job. And again, this is where we're scoring at 1 to 5 minutes, and we're scoring on heart rate, respiratory effort, muscle tone, reflex irritability, and color. And each category is 0 to 2, right? So if this newborn is now at 7, they're in a great place. They were at 4 just a little bit ago. So 7 to 10 means they likely don't need any more interventions here. So excellent job. All right, let's do this last question here before we end. Our physical examination results are apical heart rate of 130, respiratory rate of 46 irregular, intercostal retractions observed, and oxygen saturation 98% on oxygen at 24% via nasal cannula. Skin color appropriate for genetic background, mild acrocyanosis, extremities fully flexed, abdomen soft, umbilical cord clamped and drying, and mucous membranes moist and yellow. Now select the 5 findings that indicate the newborn's condition is improving. Let me see here. Okay, so what's showing us that this newborn is improving?
Oxygen
Heart
saturation.
Heart
rate,
rate,
Heart
heart
rate, yeah.
rate,
Yes,
respiration,
oxygen saturation, respiration,
yes.
and
and
degree
mucus,
of flexion.
mucus membrane.
All right, let's take a look. So we have heart rate, we have respiratory rate, we have oxygen saturation, skin color, and degree of flexion of extremities. Great job, you guys. That is definitely showing improvement. Now, we have a great APGAR score now, right? So their heart rate is good, their respiratory effort is good, they're having good muscle tone. And they're having a grimace. They're having good color now. They're no longer having central cyanosis. So their heart rate rising from 80 to 130 is excellent. This means they're having excellent cardiac perfusion and cardiac output. So they definitely have improvement here. The respiratory rate of 48 is within the range. So this means their breathing has been stabilized, right? Their oxygen saturation of 98%, they're still on oxygen, but they've improved. So this is great. This means their lung function is improving and they're being adequately perfused. Their skin color shifting from central cyanosis to just mild acrocyanosis is also showing improved perfusion, and their extremities progressing to full flexion from having minimal tone is showing us that, again, they have neurologic recovery because they've been resuscitated accurately. They have adequate perfusion now, so they're doing so much better. Unfortunately, those intercostal retractions are still showing that this child is in respiratory distress, so it's not an improvement. They're still having an increased work of breathing. And then with the moist mucous membranes, this is a good thing because they're not dehydrated, right? But their mucous membranes have a yellow coloring to them. So this could mean that they are developing jaundice. Their normal membranes should be in a pinkish color, not a yellow color. So yellow membranes could indicate that their bilirubin is greater than 5. And this could mean that, they have liver immaturity or that they have some hemolysis. So we just have to go ahead and take a look, maybe measure that serum bilirubin and see if this child may need phototherapy. But overall, you guys did an amazing job, and I am so grateful that you are all here and sharing all your wonderful knowledge with us. And I want to thank you for being a part of the NCLEX community. I can definitely repost the PowerPoint here for you if you missed it, so you don't have to scroll all the way back. It's going to take a little minute here to upload, but just when you click on it, it will download to whatever device you're on. So I hope you guys enjoyed the presentation. I hope this was helpful to everyone. I tried to keep it as focused as possible. Um, so that you guys can, get all the information that you need. But it was a lot of content to cover. So I hope I was able to answer your questions. And again, such a pleasure being here with you guys. I am wishing you the best of luck if you're taking the NCLEX anytime soon. Trust yourself, you've got this. And if you have time to join in another webinar and ask some final questions, feel free. We do have them going on almost every day. And I highly recommend that you continue practicing with the question bank because it's all about just knowing that strategy of how to answer the questions. So
Thank
that webinar is uploaded. So just go ahead and scroll up a little bit. You'll see it. Just click on it and it'll download into your device. And I hope that you guys have a wonderful rest of your weekend
Okay.
and enjoy your week.
Please, I have a
Professor?
question.
Yeah.
Professor, how about the
Yeah.
questions? Can you post them? Question and answers?
Do you want me to post them in
Here.
yeah.
Okay,
Yeah,
thank
sure.
you.
Yeah, absolutely. I can post them in here for you guys. Did anyone else have another question?
Yeah, I have a question
Yeah, go
concerning
ahead.
Professor, I have a
the
question.
moral reference.
Okay.
What age is a child supposed to stop having that moral reflex? Is it 1 year or 6 months?
Great question. You know what? Let me see if I can post here. Um, I'm posting the questions and answers for you guys here. Let me see if I can also post a timeline for you guys of all the reflexes. I'm going to go ahead and write it out here for you guys. Let me see. All right, let me see if I can. I'm trying to write it out in the chat here for you guys so you can copy it into your notes. So basically, when the reflexes persist beyond a normal period, that means that that child could potentially have a neurological compromise or a neurological problem, right? So they could have like cerebral palsy or something. Now, the Babinski reflex is one that can be normal up to a year or two sometimes, but in an older child, it would signal that they could have a neurologic issue. But when it comes to the moral reflex, which you're mentioning, that's like kind of the NCLEX favorite. It should disappear typically by 4 to 6 months. And like I said, I am trying to kind of type it out here in the chat for you guys so you guys can have a little bit of a timeline. Let me see. And I'm putting the time that it should disappear by. Okay, there we go. So you guys can go ahead and copy and paste that into your notes. Sorry if the formatting is funky. It's kind of weird typing it all in the chat here. But these are the basic timelines by which each reflex should disappear. And these should be checked for at every like milestone appointment. They'll be checking like, are they doing this yet? And of course, once baby hits about a year to 2 years, that's pretty much when their last reflexes are still going to be around, which are those Babinski and plantar grasps. But pretty much all the other ones are around 4 to 6 months, except for the stepping one that's around 2 months. So let me go ahead and upload the questions here for you guys. And
I have a question.
yeah.
Okay, I actually want to know the actual heart rate because you study this and they say from 120 to 160, and some education numbers will tell you 110 to 160. Which exactly is that?
For the heart rate?
Yes, ma'am.
Yeah, so the heart rate should be 110 to 160. But sometimes it can be 120 to 160 if the newborn is like more this in distress, you know what I mean? So they want to give the newborn a little bit of an extra boost. But for NCLEX purposes, we're keeping 110 to 160. So if baby is 115, that's fairly normal. As long as it's not a trend. Let's say it's trending down and 115 is part of a trend, then we're concerned. But if it's a single variable and it's like 110, 112, it's okay.
Thank
Yeah,
you.
so worry more about trends than when it comes to more so trends than individual numbers. And you're very welcome. I did upload everything here for you guys. So thank you guys again so much. Thank you for all your wonderful questions and excellent work nailing all the correct answers. You guys did amazing. I hope you guys have a wonderful week and I will see you next time. Take care.
Thank you.
Thank you.
Thank you.
Thank you so much. You're amazing.
I
Oh,
appreciate it.
thank you. I appreciate that.
Bye-bye.
Thank you, Professor.
Bye.
Bye.
Thank you.
Thank
Take
you.
care.
Oh my goodness, I just joined, so I missed out. I'm trying to this is my first time. So I was just trying to check out this. I was trying to check out this and sign up. Then I thought that's when it started, so I missed out, I guess.
That's okay. Go back to Naxlex previous webinars on the website. It will be posted within the next couple of days so you can rewatch it.
Okay, thank you.
You're welcome. Take care, you guys.